Hello and welcome to Radcliffe Cardiology's webinar in association with Arrhythmia and Electrophysiology Review. I'm Harriet Seeger, I'm the online editor for Radcliffe Cardiology, and I'm delighted to be joined today by Dr. Amit Mistri, a consultant physician in stroke medicine at University Hospitals of Leicester, NHS Plus UK. Today Dr. Mistri will be talking to us about anticoagulation for stroke prevention. And with the advent of new anticoagulants, it's a topic much talked about at the moment, and physicians are questioning what they should be prescribing and why. So this promises to be an opportunity to have many of these questions answered, and you can ask Dr. Mistri questions via the text box on your screen throughout the course of the webinar, and he will answer as many as we can at the end. There will also be a few intervals when we'll be asking you to vote, and then at the end of the webinar, Dr. Mistri will look at the results and comment. So without further ado, I hand you over to Dr. Mistri. Dr. Mistri, welcome.
Thank you very much, Harriet. So my name is Amit Mistri, as mentioned, and I'm a stroke consultant based in Leicester. And I'd like to talk today about anticoagulation for prevention of cardio-embolic stroke and the recent changes in anticoagulation. So I should present my conflicts of interest. I've received honoraria for educational talks and conference support from several companies that sponsor stroke prevention medications, and this includes companies with the 3 licensed oral anticoagulants. I should also add that the views presented here are my own and do not represent my employer's views. So without further ado, we are all aware that there is a significant healthcare cost following a stroke, and as shown in the pie chart, 42% of that care involves inpatient activities, and about 40% of that care is for ongoing personal care requirements in residential placements. Given the significant cost following a stroke, strategies for prevention of stroke are of high importance. There is a story of missed opportunities. Between 25 to 80% of stroke is preventable. And this can be done by simple measures, optimal modification of 3 key vascular risk factors. This includes smoking, high blood pressure, and anticoagulation for AF, the last being the focus of our topic today. Cardio-embolic strokes can be caused by several different cardio-embolic sources, and the strength of association between a cardiac condition and embolic stroke is variable. However, it is clear that atrial fibrillation is the dominant cardio-embolic source with resulting cardio-embolic strokes. So given the audience is mostly cardiology, I won't dwell too much on those aspects, but atrial fibrillation is indeed common. Up to 2% of the population can have atrial fibrillation, a lot of which is silent and asymptomatic, as cardiologists are well aware. In fact, some studies can report a prevalence as high as 14% of the population, and that is perhaps a reflection of elderly cohorts. About 5% of acute medical admission patients have AF, and this is important because not all medical specialties respond to AF in the same way. It is well documented that the incidence of atrial fibrillation is rising, looking at data from the Mayo Clinic and other studies. And irrespective of the aging population, there is in itself an independent rise in the incidence of atrial fibrillation. So we're going to see a lot more of AF and consequently cardio-embolic stroke as a result. This is just a scatter graph of how the prevalence of AF varies in different patches of the country. And you can note that most areas have a prevalence of 1.5 to 1.9%. There are some high prevalence areas and some low prevalence areas as shown on the map. And some statistics have been done to indicate that a higher prevalence of AF is associated with a lower incidence of stroke admissions. Now, this is just a statistical association, but it's interesting to note this, and it may be that screening and more aggressive programs to increase the prevalence of AF might reduce the stroke burden in society. This is a CCG prevalence based on individual areas, and on the right we've shown the English prevalence in the black bar, and the East Midlands one, which is my patch, Leicester and surrounding areas, which we are roughly on par with the English prevalence. However, if you look at individual CCGs in our patch, you can see there is a significant variation in prevalence. On the right, the lowest bars represent city populations, and it's not well understood whether this is a reflection of poor participation in screening or socioeconomic status or otherwise. AF is a well-known thromboembolic state conferring a 5-fold risk of stroke. And these strokes tend to be larger infarcts, more in the cortical distribution. There's a higher rate of mortality in these strokes, and survivors have significant disability. About a fifth of all stroke is attributable to AF, and this increases to 40% in the elderly. And there used to be a misunderstanding that asymptomatic AF has a lower risk of thromboembolism, and this is not true. And the high cost of society is clearly due to the associated stroke and other embolic events, but also due to, in the longer term, congestive heart failure and otherwise impaired quality of life. And the direct cost of AF is up to about 2.5% of the healthcare budget, and this is increasing rapidly. So the approach, I like to keep it simple, is to find AF, assess AF appropriately, and provide the optimal treatment. In terms of finding AF, one should be looking for undiagnosed AF. This is mostly in primary care, but all medical inpatients or even surgical inpatients should have a pulse check and ECG to look for AF. We should be looking for untreated AF, and primary care has a key role where patients are known to have AF, but actually are not receiving any anticoagulation. In addition, AF patients on warfarin might not actually be receiving the optimal benefit because their time in therapeutic range is suboptimal, less than about 65%. And we've talked about patients presenting to secondary care in hospital in non-cardiac or non-stroke situations where they should receive an appropriate response if they are diagnosed to have AF. And I've put it on the right, food for thought, should we be considering new or novel oral anticoagulants in all these situations? We'll dwell a bit more on that later on in the talk. This is mostly relevant to primary care physicians, but there is a piece of software called GRASP AF. GP surgeries are able to run this on their system and identify patients with documented atrial fibrillation and what kind of stroke prevention treatment they're on, which may be none, some antiplatelet, some anticoagulant, and perhaps the type of anticoagulant. It allows GPs to focus their activities towards responding appropriately to these patients with known documented atrial fibrillation. Moving on to assessing atrial fibrillation. Stroke prevention in atrial fibrillation is all about the balance between embolic events, clots, and hemorrhagic events, bleeding as a consequence of treating or preventing strokes with anticoagulation. In the recent years, we've seen the evolution of scoring systems. We used to have the CHADS2 scoring system, which is shown with the blue bars as to how it splits out people in terms of their risk of embolic stroke on an annual basis. And this has been refined further by the introduction of additional risk factors, resulting in the CHADS-VASC score, as demonstrated by the red bars. Again, you can see there's a nice association between increasing score and increasing stroke rates. These are recommended for assessment of AF and useful to try and decide what treatment they should be offered, especially from the anticoagulation aspect. And the traditional view with the CHADS2 score was that a score of 0 should be given aspirin, score of 1 could be considered for either of the two treatments, and more than 1 would result in anticoagulation with warfarin. This has been refined with the CHADS-VASC score, where 0 amounts to suggested treatment of nothing or aspirin, 1 where anticoagulation is preferred over aspirin, and more than 1 suggesting anticoagulation is likely to be of benefit. The European Society of Cardiology presents a simple treatment flowchart. This is available online if you should want to have a look, and it allows you to direct yourself in terms of the appropriate treatment. The second figure shown here is perhaps easier to use. Valvular atrial fibrillation should result in anticoagulation with warfarin. Non-valvular atrial fibrillation should be assessed in much more detail using the CHADS-VASC and subsequently the HAS-BLED scores. And you can see you can end up with either no antithrombotic therapy at the bottom, a NOAC or a novel oral anticoagulant, and vitamin K antagonist like warfarin. In recent years, we've started using a bleeding risk score also, and the most popular of these is the HAS-BLED score. The elements of this score are shown on the right. I'm sorry that the bottom one doesn't show. It's drugs or alcohol with 2 points added for that. And again, you can see there's a linear, almost exponential increase in bleeding rate per year as the score goes up. So this can be used to balance the bleeding aspects of anticoagulation and balance that with the CHADS-VASc demonstrated embolic risk. It is, however, important to note that HAS-BLED is not meant to exclude patients from anticoagulation, but to identify modifiable risk factors and to quantify the bleeding risk for discussions. For example, you may find from the CHADS-VASc that the embolic stroke risk is about 6%, while HAS-BLED gives you a bleeding risk of about 2%. This is useful for people, physicians and patients, to use in terms of the decision for adopting anticoagulation. And the ESC guidelines recommend HAS-BLED. There are other scores called hemorrhages and atria, which are less commonly used. And if you look at the previous one, for example, with regards to modifiable risk factors, H for hypertension in this instance refers to a systolic blood pressure of more than 160, so uncontrolled blood pressure. So for someone who's got a systolic of 170, you can actually modify their HAS-BLED score and bring it down by optimal treatment of hypertension. And similarly for the other risk factors where, for example, renal impairment may be correctable with IV fluids, perhaps adjustment of medications. So HAS-BLED is a modifiable risk score. You can bring down the bleeding risk, while CHADS-VASc is not a modifiable one. And if you look at real-life cohorts of atrial fibrillation patients, for example, the GARFIELD registry, which has been published recently, I'll put the online link at the bottom should anyone want to look at these. You can see that 82% of people are for anticoagulation, clearly based on the CHADS-VASc, so a score of 2 or above. A score of 1 where anticoagulation is preferred is another 15%. Essentially, that means there's only a very small 3% of people with AF who should be not for anticoagulation. From the CHADS-VASc, the embolic risk side of things. Similarly, if you look at the bleeding side of things, a HAS-BLED of 4 or above would be a high bleeding risk, and that's only a small 3.4% of the whole population. The majority of them are 2 and below at 74%, and these people are likely to have a higher embolic stroke risk than bleeding risk. In addition, the 22% at intermediate bleeding risk, it is likely that they will have a modifiable risk factor, and so you could actually bring down their bleeding risk. So overwhelmingly, only about 3% of people are not for anticoagulation based on CHADS-VASc, and only about another 3.5% are likely to have very high bleeding risk, where you have to seriously think about the risk-benefit balance. So the dominant approach to management of atrial fibrillation should be anticoagulation, and one should be looking for genuine reasons to not anticoagulate rather than the other way around. I've got no financial links with this app, but there is an app for iPhone enthusiasts called the Focus AF Calculator, and it helps you calculate stroke risk using the CHADS or CHADS-VASc and bleeding risk using HAS-BLED. It also provides a creatinine clearance calculator for choice of anticoagulation, which we will come to later. In addition, if you're working on a computer, there is an excellent website called chadsvasc.org, which you should review, which allows you to click a few buttons and calculate the CHADS-VASc and HAS-BLED risk for patients who are sitting right in front of you. Moving on, after finding and assessing atrial fibrillation, we want to treat atrial fibrillation. I will admit freely to not being a cardiologist and will not talk about cardiology approaches, things like paroxysmal AF management or rhythm versus weight management. And we'll move on straight forward to anticoagulation. So, cardiologists and other physicians are well aware of the historical trials in atrial fibrillation patients. We know that warfarin reduces risk of stroke by about 2/3. And the numbers needed to treat are very small indeed compared to other treatments. So for someone who's had a TIA or a stroke, you need to treat 14 patients to prevent a stroke every year. This is highly effective therapy. And someone who's not had a stroke, a larger number of people, so primary prevention numbers needed to treat are 40 to prevent 1 stroke every year. I have put similar figures for aspirin, but increasingly aspirin is not recognized as a treatment for prevention of cardio-embolic stroke. And the reduction seen with aspirin is possibly a reflection of stroke prevention in general with regards to other types of stroke, for example, atherosclerotic stroke. In fact, aspirin has a similar efficacy in terms of stroke prevention in non-AF populations also. A couple of very important slides to note. The risk of ischemic or embolic stroke in AF patients without anticoagulation far exceeds the risk of hemorrhage with anticoagulation. And you can see these in the line charts that are shown. On the left is a chart showing a split by CHA2DS2-VASc score. And you can see the red line, which is stroke risk without anticoagulation, is very high, going up to about 12% risk in the high CHA2DS2-VASc scores. The bleeding risk shown in the orange and green lines remains quite low, irrespective of whether or not you're on anticoagulation. But the shift from the red to the green line is dramatic with anticoagulation. And that shift persists even if you split patients by different strata of the HAS-BLED score. So irrespective of CHA2DS2-VASc or HAS-BLED spread, on a societal basis, anticoagulation is likely to be beneficial despite a small increase in bleeding in the higher aspects of the scale. Similarly, if you present the data in a slightly different format and look at all-cause mortality, ischemic stroke, and intracranial bleeds, which are the three key outcomes in this population group of AF patients, it doesn't matter which group you fall in terms of the CHA2DS2-VASc or the HAS-BLED, split out into 4 groups, mortality remains higher in people who are not anticoagulated. This is a very strong message indeed to suggest that anticoagulation is beneficial for AF patients. This brings us to the age-old saga of warfarin. We know that warfarin is labeled as a dirty drug, and that is not without basis. The effect of warfarin is highly variable, and there is an industry of warfarin clinics existing out there which aim to keep the INR, the measure of anticoagulant effect of warfarin, the 2 to 3 therapeutic range. And as you go below 2, there is an exponential rise in terms of the embolic stroke risk because of lack of anticoagulant effect. And as you go higher than 3.5, maybe even 4, the bleeding risk starts to rise because of an increase in anticoagulant effect. And the vagaries of warfarin are well known to most physicians with regards to dietary problems, missed doses, other drugs interacting, or indeed perioperative care with regards to anticoagulation and cessation of anticoagulation to enable surgical interventions. As a result, warfarin is heavily underused. And the reasons cited by physicians and patients for the underuse are listed on this slide. Clearly, there are genuine patient contraindications. If someone has had actual bleeding, one would be very wary indeed of using anticoagulation. Specifically, if you've had intracranial bleeding, then I would be quite concerned about using anticoagulation. If you look at physician decisions, a lot of them are softer decisions, in my opinion, where a physician either chooses an antiplatelet or assumes that the patient has a perceived high bleeding risk, or indeed suggests that the risk of stroke is low while the risk of bleeding is high. Hopefully I've dispelled that myth already, showing you those powerful graphs from previous studies. There are clear patient refusal reasons, for example, burden of monitoring with regards to attendance at INR clinics on a frequent basis, or indeed choice for alcohol or certain food restrictions that fall upon them if they are on warfarin. I don't think that the second and third reasons are unsurmountable with regards to choosing anticoagulation. So, what about people, real-life people who have atrial fibrillation but are not anticoagulated? I should point out that a history of falls is not by itself considered an adequate contraindication these days. This is included in the NICE guidelines for atrial fibrillation that was updated recently. And modeling studies suggest that an elderly person must fall about 300 times for the risk of anticoagulation to outweigh the benefit. Clearly, this is not real-life data. One would not be able to randomize people based on falls and anticoagulation. But this is as good as it gets with regards to getting data to support anticoagulation choices. 43% of high-risk patients are not anticoagulated in real life. In addition, if you look at the people who are not anticoagulated, exclude falls, 2/3 of people then become eligible for anticoagulation. This is, again, an important statistic. It suggests that we are not doing enough for our AF patients, and we are perhaps too soft in terms of assuming a high bleeding risk, perhaps associated with falls, and defaulting to the no anticoagulation stance. This is a powerful graphic. It is from our local area. It suggests opportunities for improving from current management to optimum management. And I will quickly go through each of the hard figures. Current prevalence in this CCG is 1.6%, and if you increase the prevalence to 2%, that should improve management of AF and reduce stroke risk. Similarly, instead of CHADS2, if you start using CHADS-VASC, you will identify a larger number of people, significantly higher percentage of AF patients eligible for anticoagulation. And if you increase the actual use of anticoagulation from a prevalence of 65% to 85%, you can see on the right that you can actually more than double the strokes prevented and more than double the hospital admission costs involved. And we're talking about large figures in terms of money here. So to summarize the initial bits, cardio-embolic stroke is bad news. It's highly preventable with anticoagulation. Warfarin has limitations, and preventive anticoagulation could be better. And the second half of the talk will be about other options. Perhaps I can interest you in voting on a couple of questions. So we're going to follow with a couple of questions. So the first one, hopefully you can start voting now. The question is, which of the following is true about AF-associated stroke? A, higher mortality. B, more disability in survivors. C, preventable event. D, likely to increase in incidence. And E, all of the above. You can vote now. I'll give you 5 more seconds for that. I can see 6 of 9 have voted. And a second question. Hopefully we can see the results of the first question later on. The second question is on now. Which of the following statements is true? Choose the one you think is true. The vast majority of people with AF should be considered for anticoagulation. B, the vast majority of people with AF should see a cardiologist. C, most people with AF are anticoagulated effectively. D, cardiologist's responsibility to anticoagulate. And E, stroke physician's responsibility to anticoagulate. You can vote for that now. And I'll give you another 5 seconds to vote for that. I'm hoping the voting is working all right. We'll come back to the votes later on. I can see 4 people have voted for the first question and 4 for the second one. Excellent. So moving along with the talk. The second half is about the oral direct inhibitors, or the NOACs as they are called. But it's a question as to how long a drug can remain novel or new as an anticoagulant. So I increasingly have started moving to the use of oral direct inhibitors rather than new oral or novel oral anticoagulants. So these are the agents that we are possibly familiar with. Simelagatran was tried a few years ago and withdrawn because of significant side effects. And we have currently available 3 oral direct inhibitors. The factor 2 inhibitor, dabigatran, and factor 10 inhibitors, rivaroxaban and apixaban. Each of these 3 have a nice technology assessment associated with them if you should like to have a look at them. And the conclusion for all these is that they are cost-effective options and should be available for patients in the country. Edoxaban is a new one, which is awaiting European approval, but has been approved for use in Japan and in America. And the three licensed agents have large trials associated with them to support their comparison with warfarin. Dabigatran was studied in the RELY study, which is a 3-arm trial, high dose, low dose, and placebo. Rivaroxaban in a 2-arm trial where there was a dose reduction if renal impairment was presented. And similarly, apixaban had a 2-arm trial in the Aristotle study. So the theoretical benefits and risks of oral direct inhibitors. One would assume if they are more reliably anticoagulating patients, you should have lower ischemic stroke risk. One would assume that there should be less bleeding risk because they are targeting specific clotting factors rather than the indirect vitamin K inhibition by warfarin. The lack of monitoring is certainly very attractive. There is a rapid onset of anticoagulant effect. Within 4 hours, most of these have started having anticoagulant effect. And there are less interactions with food and drugs compared to warfarin. What about potential harms and risks? The lack of monitoring certain patients who are on warfarin might find psychologically unacceptable because they are unable to be reassured that they are anticoagulated. There is a significant concern about the lack of reversal agents for these 3 drugs. And clearly there is a requirement for caution in renal impairment because most of these drugs are renally excreted. So just a snapshot, I won't dwell on this table in detail, but just a snapshot to allow you to view side by side the trials for these agents. Please note that there have been no head-to-head comparisons between any of the agents, and any conclusions that I draw on the relative efficacy or safety based on these comparisons should be guarded. So the things to note on this table about the randomized control trials are that dabigatran has a significant element of renal excretion. 80% of the drug is excreted by the kidneys. And with regards to the trial comparison in terms of stroke severity using the CHAS2 score, the rivaroxaban study, ROCKET-AF, had people with a higher CHAS2 score, suggesting a higher stroke risk population, which was matched by a higher event rate in terms of strokes. I won't dwell too much on the details except to summarize the efficacy aspects of the study. If you look at the mortality row, significant reduction in mortality was seen with high-dose dabigatran and apixaban in the studies, and a significant reduction of all embolism was seen with the 2 same agents. Dabigatran at a high dose, the 150 BD arm of the study, was able to show a significant reduction in ischemic stroke also, which is important to note. If you look at the safety aspects, major bleeding was reduced with dabigatran at a lower dose and with apixaban. And the other aspects were not significant. So for example, if you look at the myocardial infarction, MI row, there was a tendency for an increase in the rate in the dabigatran study in both arms, but this was not statistically significant. There is a significant discontinuation rate with all these agents, varying from about 7.3% to about 15%. And it may be that in the future we end up with a clinical decision aid. This is adapted from a Canadian study, and they chose to split it based on health economics and outcomes analysis. And you can see that on the bottom right, which is low bleeding risk and high embolic risk, they tended to choose the high-dose dabigatran. On the top left, they had a no treatment area, which is CHADS-VASc scores of 0 and perhaps 1, but a high bleeding risk or a low bleeding risk. They did add, as circled in the red, aspirin, but aspirin is no longer considered an option. And they felt, based on their analysis, that apixaban presented a good option in the intermediate zone, going from low to high CHADS-VASc, but except in the lowest bleeding risk where they chose dabigatran. I must point this slide out, which is from the NICE clinical guideline that came out in June last year. Do not offer aspirin monotherapy solely for stroke prevention to people with atrial fibrillation. So aspirin is not considered effective for prevention of cardio-embolic stroke. So cardio-embolic stroke is bad for you, it's preventable, significant bad effects from it, and we now have an option instead of warfarin where we can use one of the newer agents. Just the last 2 slides before we try to summarize. Given that we are starting a lot of patients on oral direct inhibitors now, we need to know what happens, what kind of problems do they have, and how we're going to manage them. A lot of this will be pragmatic care. So let's think about people who have an ischemic or an embolic stroke despite being on these new agents. What happens? Can we offer them thrombolysis? There is no clear randomized evidence to guide this decision. Expert evidence and consensus suggests that it's prudent not to thrombolyze within 24 hours of the last dose. There are specific tests which are not universally available that can be used to rule out anticoagulant effect from these agents. Again, their interpretation is difficult. So it is likely that thrombolysis will be difficult in these circumstances. There are case reports where patients have been thrombolyzed despite being on these agents, but it's not possible to conclude whether that is a biased kind of presentation of data. It is suggested that non-thrombolysis options may be attractive in this population, and mechanical thrombectomy is increasingly gaining favor because of recent favorable data from randomized control trials, which could be the topic of another talk. There is no real consensus of restarting these agents, but we would use the general guidance for warfarin restarting after an embolic stroke event. Roughly 0.5% of patients will have an intracranial hemorrhage every year. And again, the management of this will be supportive with regards to provision of most likely clotting agents to try and reverse the anticoagulant effect. There is again no clear data to guide when to restart, if at all, these agents for anticoagulation after intracranial hemorrhage. So, to summarize, we've gone through the data about cardio-embolic stroke. We've identified that anticoagulation is highly effective therapy, but there remains a significant treatment gap due to the vagaries of warfarin. And over the last few years, we now have other alternatives for anticoagulation, which may surmount a large section of the exclusions that we, as physicians or patients, identify as reasons for not taking warfarin. I'd like to conclude here, and Harriet will summarize, and perhaps we have some questions that have been put forward.
Thank you so much, Dr. Mistri, for an excellent presentation and provided a lot of insight and some useful tools and guidance to better assess and treat AF and stroke. If I think maybe we could first turn to the votes that have come in. We did a couple of voting sessions. If you would like to just sort of talk us through them, that would be excellent.
Excellent. So the first one was, which of the following is true about AF-associated stroke? We had 4 votes. 2 voted for higher mortality, which is true indeed, and 2 voted for all of the above, which is actually the correct answer in my view. So we've identified that cardio-embolic stroke associated with AF has high mortality, up to about 25%. Those who do survive have more disability because the strokes tend to be larger in terms of its geographical extent on brain imaging. AF-associated stroke is largely preventable with anticoagulation, and because of the increasing aging of the population and the independent increase in AF, it is likely that we should be seeing more and more of AF-associated stroke. So all of the above are true for this vote.
Okay, well that's great. There's one more vote that we had.
Indeed, and the second question, I don't know if you can see all the votes, but it says, which of the following statements is true? And 4 out of 4 have answered the vast majority of people with AF should be considered for anticoagulation, and that is indeed the correct answer. Not all AF patients need to see a cardiologist or a stroke physician, and not one of the options was most people with AF are anticoagulated effectively, which is not true. Most people are on warfarin, but a significant element of those, significant proportion of those, are not in the therapeutic range.
Okay, well done audience getting that one right. Anyway, we've also got some questions that have come through, Dr. Mistri, so perhaps you could answer those. We've talked about your options for anticoagulation. Is there one agent that is the most potent at preventing stroke?
Indeed, I will happily offer my opinion on that, but perhaps we can get the audience voting on this. So I've put a question through now as a vote, and the question is, which of the following anticoagulants... Oh, I think I've got the wrong one. Let's stop that one. Let me see if I can find the other one. Which of the following is the most potent agent for prevention of embolic stroke in AF patients? Hopefully you can see the vote. And the options are aspirin plus clopidogrel, warfarin, high-dose dabigatran, rivaroxaban, and apixaban. Please vote over the next 5 seconds. And I will stop the vote here and view the results. So everybody has answered dabigatran high dose. That's interesting. So one has to be careful about the wording of the stroke, wording of the question. It is about prevention of embolic stroke. And high-dose dabigatran in the RELY study was demonstrated to be superior compared to warfarin in terms of prevention of embolic stroke. However, one has to be cautious with high-dose dabigatran because of the predominant renal excretion, and in the over 80, the elderly population, the risk of side effects might be higher. So in those groups, one would be careful.
Okay.
However, all these agents are effective in reducing bleeding risk, so intracranial hemorrhage risk, and that is important in demonstrating that the overall stroke risk is reduced by most of these agents.
That's really interesting. Thank you. And on a related question, with regards to the newer agents, what would be your main reason for using them?
So I will put through another vote for the audience to consider if they have had previous experience in using these agents. So which of the following would be your key reason for considering any of the oral direct inhibitors? And I will stress that there is no correct answer for this, but physicians are allowed to have their own opinion on this. So I'd be interested in hearing what the audience thinks about this. So reduction in intracranial bleeds, once-a-day regime, lack of monitoring requirement, less interaction with food and other drugs, and the rapid onset of anticoagulant effect. So if you vote over the next 5 seconds, please, then we can go through all the options. Okay. Oh, no vote so far. I'm going to go back to it.
Perhaps in the meantime, maybe you could just give us your opinion if we're... Well,
Indeed. So
I think we can see a few votes have come in.
yes. Okay. So the majority of people think that reduction in intracranial bleeds is a key compelling reason for use, and I'd agree with that. I think the significant benefit of these new agents is the substantial 50 to 75% reduction in intracranial bleeds as compared to warfarin in the individual studies. And I think that will have a major societal impact by reducing disability and costs associated with stroke. I think once a day is important for rivaroxaban, but dabigatran and apixaban are twice-a-day drugs. Again, lack of monitoring is highly attractive in two patient groups. One is the working population, who do not really want to keep going back to the surgery, and in elderly frail patients who have impaired mobility and find it difficult to get INR monitoring at the GP surgery.
Super, thanks for that insight, Dr. Mistri. We've had a couple of extra questions come in. Is there a big difference in cost of each of the oral inhibitors?
Not really. There is a very small difference between one of the drugs and the other two drugs which are priced similarly. They are costlier compared to warfarin. Clearly warfarin is generic, but they reduce the cost associated with monitoring requirements in an INR clinic. Certainly, if you look at the NICE technology assessments, they are considered cost-effective based on the NICE threshold for costs. But they are roughly the same in cost.
Okay, thank you for that. And another question as regards the CHADVAS score. If hypertension is controlled all the time, is it still a risk factor that is counted in the score?
Yes, it is indeed. CHADVAS is about having comorbidities. So a diagnosis of hypertension or a few readings which cross the threshold for diagnosis of hypertension are adequate to give you a score of 1, and that score of 1 remains with you forever if you're diagnosed as hypertensive. That is not true for the HAS-BLED score, because if you treat the blood pressure down to below 160, then you get 0 for high blood pressure in HAS-BLED.
Super, thanks for that. Well, thank you so much for your time today, Dr. Mistri, for answering our viewers' questions. It's been a pleasure having you with us today, and it just remains me to say thank you on behalf of Radcliffe Cardiology and our viewers. And just a final note, we'd be grateful, viewers, if you could rate the webinar using the star rating system on your screens. And we thank you, the audience, for joining us today. So
It's been a pleasure. Thank you very much, and thank you for your involvement in the votes and the questions.
Thank you very much, Dr. Mistri, and thank you everyone, and goodbye and have a pleasant rest of the day.